Hey everyone, welcome back to another episode of the Brawn Body Health and Fitness Podcast. I'm so glad that you're joining us today. Today I'm joined by Dr. Mike Lehr, who is an associate professor of physical therapy at Messiah University, researcher, and friend and mentor to myself. Dr. Lehr has done some awesome research on elite level field hockey athletes. I'm talking the U.S. national field hockey team. And today we're going to be discussing that research. So what he saw from a movement deficit standpoint in elite field hockey athletes, and what our next steps would have been from an intervention standpoint. What exercises would we have looked for, what we would have done, and so on. So this is a great episode for any sports PT or any field hockey coach, athlete, trainer, anyone who works with field hockey athletes that wants to understand more about the sports and the movement deficits that are commonly associated in elite athletes. Enjoy this episode. Dr. Lehr, welcome back to the podcast. It's always an honor to be working with you. I really appreciate your time today.
Oh, thanks, Dan. Same here.
So for people who maybe they didn't catch that first episode we did on that 37, 1, and 24 story that you shared a year ago, would you mind just kind of giving them a quick refresher of who you are and all the amazing things that you've done?
Well, actually, let's start out with the least. The least thing I like to do is talk about myself, but I'll make this short and sweet for you, Dan. Mike Lehr, associate professor at Messiah University. That's in their DPT program. I teach human movement, therapeutic exercise principles, foundational principles, and probably the nature of this is just my movement center approach with research over the years.
Yeah, definitely. You've definitely been a movement first kind of guy. And while I think a lot of what you've been known for is at the ankle, that's not to say that you don't look at other things too. You're certainly a preacher of the regional interdependence approach to assessment, I feel.
Yeah, and I have to give kudos to Rob Wayner way back, I think in 2007 when he first introduced that model. I would say since then, probably over the last decade, it started with injury risk, and that's kudos to Phil Plisky on that. As far as my mentorship, or his mentorship to me at that point, then it went into manual therapy, and then since that time, it's actually merged. Those two have recently merged, where we're looking at the specifics of foot and ankle, and certainly dorsiflexion is a key cornerstone of most of my research over the last 3 years.
Yeah. I actually referred to you as Dr. Dorsiflexion to someone earlier today.
I stand behind it at this point too. So make things simple.
Right. And as you've mentioned, you've certainly worked with a number of amazing individuals, and you've done a lot of cool research and studies on human movement in general. And one of the most interesting ones that you've published, I found, was the article that you did assessing the U.S. women's national field hockey team. You looked at a lot of their different movement factors and movement compensations. Would you mind just kind of giving us a quick rundown of what that study was and what you were looking at and trying to assess there?
Sure. Well, this was basically based off of their 2016 roster for the Olympic field hockey team. At that time, they were training down in Spookynook. And a clinician by the name of William Cheek, basically from Lancaster, he was overseeing some of their rehab and human performance and interacting with the human performance director. And he contacted me basically with some questions regarding some movement-centered approaches, the Y balance test, and that sort of evolved into this study. So naturally, I wanted to leverage this opportunity to get the most out of it. And at that time, I was leading a group of research students, and really it's just top students within that class at that point. Actually, very similar to you, Dan. So I looked at that caliber of students and said, we can do more with this. So with that said, basically they did a lit review specifically on field hockey and a movement-centered approach and build off of some of the FMS studies, Y balance studies, and SFMA at that time, which was growing in popularity. So with that, and certainly closed chain dorsiflexion is in that realm. Also at that time, really there's thanks to the work of Plisky and Kiesel, we do have the Move Perform software that we actually had access to at the university or at the Lebanon Valley College. So we were actually able to take that data then plug it in right to the move to perform software, and generate a general appraisal of injury risk for individually and also as a team. So at that point, we basically the students and myself, along with Bill Cheeks, and then also we brought along Dr. Stan Dachau based on his just research acumen, and he was a tremendous help in the study. Wrote up a proposal for the IRB and LBC, got that submitted. At that point, we're ready to run data collections on that team at that point, and we ended up with 9 total subjects.
Awesome. So you were able to look at 9 different individuals on the Olympic roster for the U.S. field hockey team at the time. And you mentioned that you did a lot of different functional movement type testing. So everything was based on, you mentioned the FMS battery, or was it the SMF battery, or which approach did you use to assessment there?
Yeah, and excellent question, and that's really the key of this, right? So we were able to basically use a station format with the nine athletes, and basically Bill ran the FMS station. We had the students run the Y-balance stations and closed chain dorsiflexion stations, and I took on the SFMA component to that, just in terms of reliability and standardization for the methodology.
So you kind of looked at all of the different movements then, right? Because FMS is a nice kind of basic look at something like an overhead squat pattern or like a standing twist test. Whereas the SFMA, I love how they incorporate the use of the rolling, so prone to supine or supine to prone, to assess more of a dissociation between the shoulder and the hip through rotation, which for a sport like field hockey, that rotation ability is pretty crucial, I would say.
Yeah, absolutely. You hit it on the head. So the initial screen included just looking at the criteria and applying the criteria of the FMS, then followed by basically looking at those thresholds for closed chain dorsiflexion, 35 degrees or lower, as being the, at least the bare minimum in terms of injury risk at that point, mainly for ankles. And that was based on a previous article, I think Pope, and with some of the military personnel. So that's my research geeked out moment for your podcast. But then we looked at certainly composite scores, Y-balance, asymmetries with that. And then with the SFMA, we looked at the top tier movements, and then I actually broke out those movements that were dysfunctional and non-painful. And then we did look at rolling with that as well. So we were able to actually break it down. And really the way I like to look at this, and this is something which I learned from my mentors, such as, with Gray, Lee, and Kyle and Phil, they're basically sort of break these up, look at the patterns, and then break down those patterns into key parts. So the one thing that really came out with the results, which was pretty fascinating, is looking at basically 100%, so 9 out of 9 athletes actually demonstrate extension movement dysfunction. That was basically non-painful.
Interesting.
89%.
So by dysfunction,
yeah, go ahead.
By dysfunction, do you mean just limited motion, or like inability to maintain spinal extension from a strength standpoint, or what was the main deficit associated with extension?
Yeah, great question. So at that point, you're looking at that gross movement pattern, and there we just apply the qualitative criteria from the SFMA with that. So, with those specific criteria, you're looking at, do you get basically the anterior, basically hip shift at that point, and what does the low back look like? Because it increased the lordosis at that point. And then you're looking at where the scapula falls relative to the calcaneus. So those are the main ones. And then certainly looking at just these uniform curves of the spine. Are you seeing that extension in thoracolumbar area, or do you see it more specifically at one segment? So at that point, without giving specifics, maybe proprietary information with the SMA on each qualitative criteria, we applied those with each one of those movements.
Gotcha. So you looked at the extension, and then you're in the middle of saying that 87 or 89% of athletes had a dysfunctional single leg pattern as well.
So extension actually floored me and surprised me most. But then this was another thing that surprised me. So we did frequency distributions on this data, and then we found that basically 100% had that dysfunctional extension pattern. But then we saw 89% had a dysfunctional single leg stance. So you imagine at this level of Olympic field hockey players, and that was tested simply static stance, hips flexed to 90, eyes open, then eyes closed. So at that point, we saw most of that basically deficit dysfunction. Again, this was non-painful. Basically, specifically when they closed their eyes. Okay, so that was something, and then the third was basically for the squat. So those were the top three dysfunctional patterns at that point, and the squat had a frequency distribution of 77%. So we had 100%, 89, 77% looking at those key things. And really, it was so surprising to me. It's just that the fundamental nature of these movement requirements and just what we were seeing in those athletes.
Yeah, definitely, because a lot of those motions, especially just simple body weight squat, I'm sure that the majority of the athletes that play field hockey and are part of some formal strength and conditioning program are doing some type of loaded squat on a regular basis. So the fact that they're displaying movement compensations without the load even is certainly interesting. Was there any specific deficit that you noted within the squat that made it dysfunctional? Like, were you seeing more of a lateral shift, or were you seeing more of like a butt wink sign, or what specifically, if you can share that, were you seeing there?
Yeah, great question. So basically what we did was, again, we just applied the qualitative criteria for the squat with the SMA. We're looking femurs parallel at that point. We're looking at, do we see that lumbar flexion with some thoracolumbar thoracic extension with it? So basically there, we're looking at no presence of any kind of valgus collapse at the knees, and no presence of an asymmetrical weight shift. So those are the key things. And now with that, we basically then, okay, at that point, we only know that they have a dysfunctional squat according to that criteria. So we really don't know why. So that's one of the benefits of really that I found just using that SFMA system, where you systematically break those things down. And at that point, certainly from the research we've done at LVC before, we do see a strong correlation between closed chain dorsiflexion range and squats. Now with this, the way the statistics sort of bear it out with just frequency distribution, and again, that's all we did at that time. Basically, here are the impairments that really came out, and you sort of hit it on the head right away. So we saw anterior hip mobility being a key, basically a key impairment and theme across these athletes. So at that point, we're looking at 56% of those demonstrated some kind of anterior hip mobility at that point. Now, with that, could it be due to an anterior hip capsular tightness or muscle tone, or any kind of potential, iliopsoas from the Thomas test? So basically, between Faber test and iliopsoas, or Thomas test and Faber test, we were able to identify anterior hip mobility deficits in terms of frequency, and there we saw 56%. So that certainly could impact any of the top three patterns at that point. Now, in addition, you mentioned that the top one, you mentioned this already, and that was the core and rolling motor control assessment. So there we looked at supine to prone, upper and lower extremity initiated, right versus left, and repeated prone to supine. So at that point, that was the highest frequency of basically dysfunction, and that was 78% across the board. So you mentioned before, in terms of transverse plane mobility and just functionality as it relates to field hockey and other sports, just life in general, that is a key fundamental movement that basically we incorporated into the protocol. And I believe there was an article that was just looked at rolling revisited, and that's with the I believe the International Journal of Sports Medicine, with I think the public basically the author was Barbara Huggenboom and Mike Voigt as well. So they're really doing good work and expanded on the original article. So I think you're going to see this more, certainly. but that was at the 78%. And the last but not least, and then I think you probably have another question, but was thoracic mobility. So there, thoracic mobility, we actually saw 33%. So a third of those demonstrated either right or left, basically right or left thoracic mobility issues.
Right, right. Through extension and rotation. And I believe that the thoracic mobility issues always presented with someone who had the anterior hip mobility deficits that you mentioned earlier, which I kind of found interesting because normally we think of the hips and we kind of think of like lumbopelvic hip complex as one thing, whereas the thoracic spine is something completely different by our old line of thinking. And now we're saying, hey, look, we have anterior hip deficits and we're seeing compensations or a correlation of compensations in other regions like the thoracic spine through extension and rotation as well.
Absolutely. So there you are seeing where if you do have a mobility deficit, we are seeing impairments in the other adjacent regions, which sort of links the regional independence model. And certainly it goes back to Gray basically always preaching more than teaching with this mantra where the body will always sacrifice quality of movement for quantity with that. So at that point, I just found, there is certainly connection of the thoracolumbar hip complex, especially when it looks at the demands in terms of the transverse plane movement requirements with sports. So this, I could see applying the same protocol to the overhead athlete.
Definitely.
Tennis players, golfers, those kind of things where you're in baseball, softball. So, the one thing I always look at in terms of motor control, you mentioned it earlier, where we're really leaning away. And this is from a person who has a fellowship in manual therapy and who was brought up with a biomechanical model sort of entrenched, and now we're seeing, and unfortunately we're seeing that evolution of that model. Certainly we can thank Joel Belaski for that we know there's more things going on with manual therapy than particularly just biomechanics, rolling and gliding. It's a central nervous issue, and certainly with the trend towards motor control, we look at it's a total body issue. But at that point, also some athletes can be good compensators without increasing load on some areas, and then other ones can be overpowered and actually, is a detriment to themselves and increased risk for future injury, which really goes down to, and one thing I didn't get a chance to mention is, so we put all this data in and we put it into Move Perform software algorithm. So that's an evidence-based algorithm. And again, there's some proprietary information, which I will respect. But at that point, there you're able to put that data in, and then it stratifies that injury risk based on 4 categories: substantial risk, which is the red light, nobody wants to be in there; optimal risk, which is ideal; and then there's 2 other ones: moderate risk and slight. So at this point, fortunately, nobody fell in the substantial risk category. Okay, but nobody fell in the optimal risk category either. So that left 4 out of 9, or 49%, in the moderate risk category, and then basically the other 54% in the slight injury risk. So we've handed this information over to the human performance director basically to consider and inform future training practices.
Gotcha. So did you follow up with them at all in the future about, the outcomes, or was this like a predictive validity kind of assessment where, you looked at these movements and later followed up and said, hey, the ones that were at a higher risk actually did get hurt and here's what happened? Or
Yeah. So at that point, with this study, just the methodology, this was a descriptive observational cohort. So basically, we went in one day to look at this data at that point, but there was no regressional model or follow-up at that point. And certainly, we have to accept this was one of the limitations of the study too. And it would have been nice if we were able to have that extra, component where we look down the road what injuries were sustained in those individuals and at what time, to make some kind of potential link or association with that. But that was not part of a methodology. But that would have been great to sort of move the discussion forward. I agree.
Definitely. And on that point for a second there, in your experience in your 20 to 30 years in physical therapy, I mean, you've been a physical therapist for about as long as I've been alive, Dr. Lair.
Yeah,
Um,
thank you for that.
what kind
You're
of
muted. You're muted. I can't hear you.
what
No,
what
go
kind
ahead.
of what kind of trends, patterns have you seen in field hockey athletes across the years there? Has there been any like one injury or one common complaint that you see more than others?
Yeah, and I could say just full transparency. I have not dealt with a lot of Olympic field hockey athletes. I mean, this was actually a learning experience for me, and I got to thank Bill Cheeks for sort of informing me of that. They did have an injury tracking system, and they did provide an injury, basically some injury data to me prior to that, prior to the lit review and the project. The one big one that really came out was certainly low back and hamstring.
Mhm.
You do have some of the ankle sprains, basically here and there, but that is one thing that really came out. And then, ironically, it's just iliopsoas tendinopathy. So you saw a lot at the lumbopelvic hip girdle that, in terms of uh, some tendinopathy strains and these potential non-contact injuries, which I really honed in on, just to try to identify some of these intrinsic modifiable risk factors with the basically with the exam.
Yeah, yeah, definitely. I think there was even another study. You mentioned the hamstring. I think there was another study by Brawn in 2015 of all people, that kind of compared like a sport like field hockey to a sport like lacrosse and looking at knee injuries specifically. Like you, I haven't necessarily worked with the Olympic field hockey team, through and through at this point in my career. But I have seen a number of high school and college field hockey players, and I continue to notice a lot of like lumbopelvic hip complex dysfunction. And I have seen some of that foot ankle stuff that you've mentioned, but a lot of times I've noticed that they'll come to me complaining of knee pain, when in reality, the knee is not the main issue for them. It's issues up the chain or below the chain instead of something directly at the knee.
Yeah, great point. And there is a neuromuscular sort of thought process that could lend itself to some of the clinical reasoning of why that is. And we can start with basically there's two particular articles of interest that emerged from the Lit Review, which I really love. The first one was Fenedy in 1992, which was I was in high school, and I don't want to know where you were, Dan, but no, I was actually in college. I wasn't in high school, so that isn't that bad. But they're reported just with the flexed, continuous flex posture with that, and they looked at how you can run in that flex posture with the ball. That ball has to be almost between your base of support for you to maintain your balance. Now, so at that point, now when you run without the ball, you're more upright. So then it's going to create more demand on your iliopsoas. So the one thing that certainly came out with the extension and anterior hip mobility seems to be, if there is sort of, and I hate to say one missing link, but the one common theme would be that iliopsoas muscle, and
Right.
particularly that led to the uh, let me see, Kawalek, Kalolek in 2013. It was basically a study with a Polish field hockey team where they looked at hypertonicity of key muscle groups. And they looked at Thomas stretch and identified the iliopsoas as one key muscle that was impacted. So basically on there, if you have based on some traditional models from Yonda, and I don't think you've met with me at all until I've actually said Yonda, so might as well insert it here, Dan. But when you have a tight or hypertonic iliopsoas, you can, which is over facilitated, you could inhibit the antagonist musculature, which would be gluteus medius and maximus. And if they control that femur and that valgus alignment, it could throw off patellar tracking, stress knee structures down the chain. So that's sort of where I'm at in turn, trying to understand that at that point. But that's what I got for now.
Yeah, no, definitely. And it's interesting you bring that up. The Yonda model and the overall hip flexor approach is I feel like there's been a lot of people who come to me and they'll complain about the hypertonic or the tightness of their hip flexors. And there's times when they truly are tight muscles and you really can't get any extension motion. And, I like to do a objective strength testing measurement on that. So we use a Tindex system here. And a lot of times they'll have stronger hip flexion than hip extension, which matches perfectly to what you just said of we have a overpowered muscle group inhibiting another one. There's always that one or two times though, and it doesn't happen often, but every now and then someone will complain about a muscle being tight when in reality it's very, very weak and they have plenty of length and mobility. And the hip flexors are one that I've actually seen that occur with, where you've got trainers and strength coaches and even athletic coaches who have been almost conditioned in a way to stretch the hip flexors because they're always tight. And while the majority of the time that's correct, there's always that one or two cases where they actually have plenty of length, but there is minimal to no strength of it. And I find, at least from my experience, that sometimes that muscular tightness complaint can actually be more of a guarding response or a guarding mechanism in someone who doesn't have enough stability to match the amount of mobility that they have.
Absolutely. And that's an excellent point, because actually experienced the same thing with the patient populations, where you feel that tightness, the palpation, you have some tender points, but then Thomas tests and some of the muscle length tests just really don't reveal that like you expected. So there I'm looking at, is it more of a muscle length stretch weakness to a degree, or lengthen weakness where it's so long to a point where maybe from length tension relationship it's not optimal at that point. So yes, absolutely, that makes sense to me.
Now, you've also done a great deal of work in the past on injury prevention program development, especially with exercise and correctives and that sort of thing. So taking the data that you had from the field hockey article, where you saw things like limited spinal extension or dysfunctional single leg stance patterns or dysfunctional squat patterns, if you had to take that group and you had to implement a corrective exercise program with them, what kind of exercises or interventions, what kind of things would you be looking at for, field hockey specific athletes based on what you saw in that article?
Sure. And glad you're not putting me on the spot or anything at this point.
I always do that, right?
No, this is a great question. Okay, so based on what I would do now, based on the research, and the reality is I've never hit a field hockey ball or been in that stance. So, this is what I would say from a neuromusculoskeletal standpoint. I will look at the regions, one for thoracic. So certainly thoracic region, I would make sure they had the mobility in terms of right versus left, and as symmetrically as possible for that. Now, is some data in some systems that suggests 50 degrees of thoracic rotation, specifically in that region, is ideal. And I think they've applied that to golfers, and I would stick with that. So first off, I would go to thoracic mobility. One, that's my bias. Because I'm a manual therapist. So I like to think manual therapy still has a, advantage. And I would say that thoracic region would be a manual therapist dream in most of these athletes.
Well, yeah, you just get to punch their ticket to Thoracic Park, right?
something like that. Yes. Also, then I take my manual therapy skills to basically to the hip. I would want to rule out any kind of particular anterior hip joint restrictions, and if so, I would attempt some mobilizations, manipulations, and some soft tissue work there. I'd get out instruments, and I'm a big advocate of dry needling, even though we can't, not necessarily doing it in PA based on some restrictions with the Practice Act. But then I do instrument assisted soft tissue if needed to detonify, and I think I just made that up. But
I like it.
Iliopsoas. But yeah, I basically look at those key things, and if it's truly tight or hypertonic, I try to normalize that or reduce some of that neural activity in that muscle, and then I'd really go after the hip in particular. I would make sure some corrective exercise, single leg or basically single leg bridging. Big fan of bridging and just how you can lock out that lumbar. At that point, avoid that hyperextension, which you see in so many of these athletes. So I do that single leg bridge where you actually bring that contralateral knee to the chest, and then you're bridging with that. Plus, I like that in terms of their hamstring injury data as well. So there you basically, hopefully you're taking out the hamstring, at least to some degree, where you're making that basically actively insufficient based on traditional biomechanical models. And now you're relying on the primary mover of the hip, which is the glute. That just seems like it makes a lot of sense to me with that. And then certainly core and rolling. Getting into looking at those transverse plane patterns and getting their basically rolling back in a good functional way, particular prone versus supine. And that could be upper extremity or lower extremity initiated, because at that point, looking at those patterns, I think you really get an appreciation of moving just in an unloaded position in a primitive pattern. So that's where I probably start. And at that point, certainly in the presence of closed chain dorsiflexion restriction, I'd be very careful with some of these loaded squat positions. I'll be very careful about some of these plyometric activities in that presence, because then you could potentially compensate by most likely pronation at the mid-tarsal joint. So then you get into some of those tendinopathy issues, such as posterior tibialis dysfunction, Achilles, plantar fasciitis, which we did see those in an uptick with some of the injury data.
Yeah, that's interesting. And, I'm so glad you brought up the point about compensations at the midfoot or other joints of the foot and ankle, because that's one thing I've noticed a lot for myself across the board with athletes is sometimes they'll show you great closed chain dorsiflexion motion, but when you lock them into more of a neutral position, I usually hold them in like a subtalar neutral and try to prevent any side-to-side motion at the foot. All of a sudden, their dorsiflexion actually kind of sucks. A lot of people will compensate with other patterns like the pronation in order to make up for the lack of dorsiflexion. So I'm glad you brought that up.
Absolutely. And we actually, based on what you just said, we saw the same kind of thing. So in a future study, I sort of wised up a little bit. I'm learning even my old age here, where we wanted to, thanks to the help of Stephen Petneo from Temple School of Podiatric Medicine, he was able to give us a medial longitudinal wedge. So what we're able to put in to actually support that joint, so you're isolating more of the talocrural joint. So we did that in my dissertation, and I'm looking to finally get that into some kind of peer review submission just over the next 4 to 6 months. So that's my timeline there. But absolutely. So one way to do that, if you don't have that wedge, you could basically instruct that patient to bring that knee, basically keep that lateral to the second toe as well. So that's one way. If you see that knee collapsing in the first MTP or medial to the first MTP, you look at the medial longitudinal arch and that navicular, it's most likely it's not cavus at that point. You could be pronating. So those are some of the instructions you could use to implement during that closed chain procedure. And what we see from the clinical practice guidelines and the research, really open chain assessment of dorsiflexion has been shown to be unreliable, and we got a question of validity there. And it's there, I would say, where you're looking at weight-bearing lunge testing, there you're seeing much more validity. You're seeing the reliability in the realm where this is these are good ways to look at this kind of construct.
Yeah, definitely. I'm glad you brought that up. And, I heard you mention a number of great interventions there, from rolling to bridging. And one that I'm kind of surprised you didn't bring up actually was the chop and lift and the clamshell.
Yeah, I would say definitely clamshells, and we can't get off this podcast without saying PNF chop and lift. But they're basically that's where I would go with that. I mean, certainly with the clamshells, good for isolation, and really a good injury prevention program would be something that addresses the key parts, right? But then also addresses the key patterns. So that's where you get the neuromuscular re-ed. So once you get into these tall kneeling, half kneeling, PNF chop and lifts, and then more functional patterns, basically in closed chain environments, there you're using the whole body system. So I just love the idea of, progression with that.
And yeah, I'm glad you brought up the chop and lift. And I mean, next thing you know, we forgot the serratus posterior muscle and its role in all these field hockey things. So we'll have to get that one next time, I guess.
Dare to dream.
Dr. Lehr, we start to wrap up here. Do you have any kind of closing thoughts, closing remarks, or anything that we might have missed on the topic of field hockey?
No, not at all. Just want to appreciate your time, the good work you're doing in terms of blending and fusing sort PT, sports medicine, with basically interprofessional education and human performance. Certainly, the more professionals and different disciplines, perspectives are talking about serving the most important person. That's the athlete. I think we move the science forward.
Definitely, definitely. Always appreciate your kind words and really appreciate your time, Dr. Lehr. I know it's hard to come by, and looking forward to catching up again with you very soon. Thank you again.
Okay. My pleasure, Dan. Thank you so much.
Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.